Welcome to another multimodality imaging conference. Also, I want to say that you can get a CME credit. The number on the flyer is wrong because of the new year. It's a new one, 43781, for the ones that they like to take a CME credit. Today we have a presenter from Mount Sinai Morningside, Dr. Bimal. We have an interesting case, and also we have a great panel. Dr. Kukar, from the Director of Cardiovascular Imaging from Mount Sinai West. Dr. Patel, Director of Cardiac PET in Mount Sinai Morningside, and also doing a lot of research with the topic that we will discuss today. And also Dr. Sweeney, who's the Director of the Lauder Cardiovascular Center in Mount Sinai Fuster Heart Hospital. And I know Dr. Sweeney may have to go because he has a patient with acute MI waiting in the cath lab, but we appreciate him coming even for a few minutes. Also, we have other sites from Mount Sinai Morningside, Mount Sinai West, and also would like to tell them to participate and ask any questions. And we'll leave 5 minutes in the end for any questions from all the other sites. Again, welcome, good morning, and Dr. Bimal, you can start your presentation. And we have our moderator, Dr. Bisto, great moderator for today.
Good morning, everyone. So we have an interesting case of a 54-year-old female with no prior cardiac history who presents to the ED with one-day history of bilateral chest discomfort and chest pressure radiating to her neck with associated nausea. On presentation, her vitals were significant for a blood pressure elevated to 172/109, but were otherwise stable. Her initial physical exam was significant for her being in mild distress, but was otherwise unremarkable. Her initial EKG showed ST segment elevations in 2, 3, and ABF, depressions in lead 1 and ABL, V1, and V2, consistent with the infraposterior MI.
Also, I would add the lateral pili leads also have ST segment elevations. So it's infraposterolateral, just extending it a little bit further. It wasn't bad enough.
Okay. Her chest X-ray was normal. A STEMI code was activated. Medications given in the ED include aspirin, ticagrelor, and heparin. Medications given prior to cath include intraarterial heparin, verapamil, and nitroglycerin. This is the LV gram. I'm sorry.
So let's stop here for a second. We have our cath expert here, Dr. Sweeney. Dr. Sweeney, if you're just able to take us through the cath images, please.
So the first image on the left, obviously everybody knows, is a LV angiogram. This is done with a guide catheter. Here, very quick assessment. It doesn't show any regional wall motion abnormalities on our assessment. Do you know what the end diastolic pressure was at the time?
I'm not too sure. I don't know.
That's part of the important part of doing the LV gram is understanding the hemodynamics. And this isn't an RAO projection. This is an LAO projection to allows us to look at the lateral, inferior, and septal walls. Not really that well appreciated there. Maybe some inferior to lateral hypocontractility, but I'm waving my hands on that. You can go to the next angio. So this is the left coronary artery. In a apicaudal view on the left, you see the circumflex coming at you, the LAD going up, and a large ramus going down. On first glance here, there's no obvious occlusion, there's no obvious cutoff. You do see some tortuous vessels in the distal segments of that circumflex and in the LAD. And then in the cranial projection, again, this is a very smooth LAD without any obvious culprit area. Now they're engaging the RCA, again, very smooth. And then this is the cranial projection that lays out the posterior descending in the RPL branches, and I don't see anything obstructive here in the large epicardial vessels at all. Obviously, the small vessels we can't see on a standard angiogram done in the cath lab, but given the EKG, I would focus largely in the posterior lateral area. So the distal circumflex and the RPL system in PDA. But right here, I don't see anything sticking out to me as something that is obstructive.
So her initial labs were significant for an elevated white count. Initial troponin was 46. LDL was elevated to 188. Second troponin after the cath was 2,318. After the cath, patient was admitted to the CCU. Post-cath, this is her EKG, which shows Q waves in 2, 3, and AVF.
She also has grown taller, she has also grown taller R waves in V1, V2, so it's the posterior component of the inferior part. I don't remember about the lateral leads, whether it's any different.
Yeah, they look like,
It's a fair size infarct.
yeah, definitely the tall R waves indicating like a Q wave in those posterior area.
Okay. Her echo.
All right, so we have a lot of imaging experts here, but I'd like to call on Dr. Kukar to take us through the echo. We have some non-contrast enhanced images, we have some contrast enhanced images. So we'll start here.
Sure. So on the left eye, you have peristernal long axis shot, where you can see the basal infralateral wall is contracting, and it's not as clear, but it does look like there's some possible focal hypokinesia at the mid infralateral wall. On the right, in the 4-chamber shot, I don't think you can really appreciate as well, but possibly some apical lateral wall is not well seen, which we'll see better as we go on. All right, now you have some contrast shots here, short axis on the left side. Difficult to kind of make out, but there's some, again, regionality with some focal severe hypokinesis, maybe akinesis of that infralateral wall. On the right, in the 4-chamber with contrast enhanced images, you can see that there's a clear hinge point where there's a mid-lateral wall area of akinesis. It's actually interesting in these shots, just again, hindsight 2020, but with contrast, you can do, assess perfusion to some degree. And potentially, maybe there's a little bit of, echo or coexist with perfusion with this contrast in that mid-lateral wall as well. But I think we'll see it more clearly later. You can go on. Okay, on the left, maybe some mild hypokinesis in the 2-chamber shot on the inferior wall. I'm not as impressed about that. On the right, you've got an apical 3, where again, you can kind of appreciate subtle focal akinesis of the mid-infralateral wall.
Okay. So, as we discussed, this is the echo report. So, on her CCU stay, days 1 to 3, on day 1, atorvastatin was started. On day 2, patient had sinus tachycardia with mild shortness of breath. She also had elevated inflammatory markers. She had a trace pericardial effusion on bedside echo. Colchicine was started. Day 3, NSAIDs were started. So this is her ESR and CRP trend throughout the hospital stay and thereafter. She came in with a normal ESR and CRP, but on day 2, it started to elevate. This is her troponin trend, and by day 2, she had peaked to 28,871. Days 4 to 6, there was pruning of the posterior lateral branch seen on the angiogram. SCAD was suspected. Colchicine and NSAIDs were stopped. DAPT was resumed. Beta blockers were started. A CT chest, abdomen, pelvis was ordered to evaluate for fibromuscular dysplasia. And this is the CT chest, abdomen, and pelvis, which was normal, and also carotid CT was done, which was also normal.
We can just let this play. Dr. Larakis is asking why it was done. So because of this quote unquote pruning that was seen, they thought, okay, maybe this is SCAD, the troponin, 28,000. So SCAD and FMD go together. Okay, let's see if there's FMD. If there's FMD, then we think, okay, maybe SCAD's even more likely here. And they ruled out an acute aortic pathology here. The aorta was normal, and they also ruled out any FMD here in the image chest, abdomen, pelvis. And as Tia mentioned, they also did a carotid assessment looking for FMD, which was normal as well. Dr. Sweeney?
So on the angiogram, so angiographically, it's sometimes very difficult to diagnose SCAD. We typically think of three types of SCAD when we look at an angio. Type 1 is the obvious one where you have staining in the arterial wall, you have hyperlucencies in the lumen, and these can be anywhere in the segment. Type 2 is a little bit different. It's more of a hematoma around the vessel and some diffuse narrowing. And type 3 is the one that we really confuse a lot with what we call this distal pruning, one of the distal segments. It's very, very difficult to diagnose because very few of us will actually put a catheter down there to image it, never mind a wire. So we never really diagnose that definitively with imaging, which is really the imaging of choice when you're in the cath lab to diagnose SCAD. But the rule of thumb with SCAD is not to interrupt that inflammation.
Thank you. Also here, you know, it wasn't a study really protocoled for PE, but actually there's nice opacification in the pulmonary artery as well, which didn't show any evidence of PE. So, you know, in the notes, they said, okay, there's no acute aortic pathology, there's no evidence of PE, and there's no evidence of FMD. That's what they got out of this CT scan. And as Dr. Sweeney mentioned, it's very important. They didn't do intracoronary imaging at the time, or
But I don't know that I would have.
right.
That's a soft call looking at the RPL.
Right.
I don't know that I would said it was SCAD. Sometimes we say that just out of diagnosis exclusion. And if you're entertaining SCAD, again, you don't want to necessarily do imaging at that point, but so I don't know. It's a tough diagnosis to make right now.
Agreed.
You also have to ask the question, does the coronary territory match
Right.
wall motion abnormality and the ECG? Do they all fit together or not?
But there are a whole list of other things that can present with what's termed as a myocardial infarction with non-obstructive coronary disease, or MINOCA. And SCAD is certainly one of them. But I know Krishna is here to talk about that as well as I can. She knows this field very well. But I unfortunately have to go.
Okay. Yeah. Thank you. That's great.
Kidding.
Thank you, Dr. Sweeney. Appreciate that. And again, I think it's important. At this point, you know, there was this MINOCA, right? This MI with non-obstructive coronary arteries. And I think with the large troponin elevation, people were like, okay, did we miss something? And I think that's when they started going back, looking at the coronary angiogram and maybe trying to pick out things. But as Dr. Sweeney mentioned, it's really tough. And something we get asked a lot in the CT lab is, oh, can we do a CT? That might be better to look for SCAD. And actually, it's usually a lot worse because we can't see distal vessels that amazingly with CT. So invasive angiography is the gold standard. And it's a lot of times very tough to call. So right now, we still don't really know what's going on, but we know that we have a MINOCA process going on. Dr. Patel?
No, so I agree with you. So also currently, I think our presumptive diagnosis. Hello. So currently, I think our presumptive diagnosis is MINOCA, as you mentioned, right? MI with non-obstructive coronaries. And whenever we think of that, it is not a diagnosis in itself. It is basically a presumptive diagnosis. We don't really know the cause of it at this point. And here is where the first thing you would do is, as we did, you know, go back to the angiogram and make sure that we didn't miss anything. Did we miss like a small plaque or something like that? Intracoronary imaging can be helpful, but again, when you suspect SCAD, you don't want to really do anything at that point. And then the second thing you do is you want to make sure that kind of causes of type 2 MI have been ruled out. So, PE, we've ruled that out. Sepsis, it doesn't present like a sepsis picture. There's no anemia, anything which would account for such a significant troponin bump. So it does look like a real MI. The other thing we need to rule out is MI mimickers, such as myocarditis or Takotsubo. Takotsubo we've ruled out because we looked at the echo, doesn't look like Takotsubo. But myocarditis also is something, a possibility that we need to rule out, given that some of the inflammatory markers are also elevated. And the best next step in this situation, not having a diagnosis, is a cardiac MRI. We have a lot of data which shows that early cardiac MRI within 7 to 14 days in a patient with presumed MINOCA can help us rule out MI mimickers and also give us a diagnosis in as many as 3/4 of patients. There's still about a quarter of patients where we wouldn't know the diagnosis, but MRI can give us a diagnosis on a lot of patients. So that is what I will do next.
All right, great. So let's move ahead in the slides. We may have given away one of the audience response answers, but maybe people might want to disagree with Dr. Patel. We'll see. So yeah, take us through, Dr. Patel.
So just to summarize, we have a patient with symptoms of ACS, with myocardial injury, with non-obstructive coronary arteries, with echo showing wall motion abnormalities, with elevated inflammatory markers, and a CT chest abdomen pelvis without evidence of aortic pathology, PE, or FMD. So we would like to ask you, what do you think of the differential diagnosis?
So while we're getting poll everywhere up, yeah, if you can use the QR code here, get into the poll everywhere. So you could say MINOCA here, but maybe that's a little too easy. Maybe you want to talk about which of the MINOCA or MINOCA mimickers, as Dr. Patel was talking about, do you think is really going on here? So let's go, there we go. Oh, okay. So a lot of MINOCA, we got a myocarditis. Microvascular, myopericarditis, Takotsubo, vasospasm, vasculitis. These are all really great things. I love these word maps. You could always say something and then you could see the word map change. All right, great. So myocarditis, myopericarditis, microvascular, Takotsubo, spasm, recanalized, I see vessel there, beanstalk syndrome. All right, someone said that. That's always at the top of every differential. You have to always keep that in your mind. But this is a great differential diagnosis, and I think this really takes us well to the next question.
Okay. Sorry. So what would you like to do next?
So let's activate this.
Oh, sorry.
There we go. All right. So we were skewed a little bit by Dr. Patel. Okay. Oh, there we go. Intracoronary imaging with OCT and IVUS. There's another answer choice. I think there's E also, right? There we go. Send the patient home as the coronaries are normal on angiogram. One's picking that one. So MRI, coronary provocation testing to look for spasm, intracoronary imaging to look for, thrombus or intimal tear, dissection, PET, which we have Dr. Patel here, so you might want to. And then send the patient home. Okay, so 82% are saying cardiac MRI. All right, if that sounds reasonable, as Dr. Patel mentioned. So now we can go to the next question.
Okay. And the next question is, what do you expect to find on the cardiac MRI in this patient?
So this is a little bit of a higher level question for people that have rotated with us on CT and MRI. what do you expect to find on parametric imaging? So that's T1 and T2 times. And then also, what do you expect the scar pattern on late gadolinium enhancement to look like? So again, there's maybe the third years in the room who have spent some good time with us. Maybe. So elevated T1 time, normal T2 time, diffuse LGE, elevated T1 time, elevated T2 time, and a focal LGE, normal T1, normal T2, no LGE, normal T1, normal T2, focal LGE.
It's not active.
Oh, sorry, activated, yeah. I thought just people were bashful. No,
No, it's not us.
it's not, you guys are not bashful, I get it. We'll let some people respond here. Let's see if people are skewed by the initial preponderance of B. It looks like they are. All right, very good. All right, so it looks like most people are choosing elevated T1 time, elevated T2 time, and focal LG, which I think makes a lot of sense, but we're gonna get into that a little bit later when we go through the MRI. But definitely B makes a lot of sense in an acute MI pattern.
Explain what
Yeah.
it means for the.
Absolutely. So I think we have some slides coming up showing exactly what T1 and T2 are and looking at the LGE as well. So they did get a cardiac MRI next, and we have two cardiac MRI experts here on the panel. We'll start with Dr. Patel. If you could just take us through the cardiac MRI.
Sure. So these are scene images, right? So you can appreciate all the walls pretty well. The function of the heart looks mildly reduced, but you can kind of see that inferolateral and lateral wall from the kind of base to mid. We don't see the apex yet, but around kind of base to mid inferior inferolateral wall is akinetic. The other thing you see is this kind of black density in there, which could be calcium, which could be necrosis. We don't know yet, but there's something within that akinetic zone that we also appreciate. Otherwise, the other walls look okay.
No, I agree. So there's focal wall motion abnormality, as we saw on the echo, but obviously more pronounced. This is actually done post-contrast, which is why you're seeing this, kind of black area in the inferolateral wall, which is not typically how we run the cines, but actually winds up looking very nice on this. So you can really appreciate that. You think it's like lipoma, you think it's, obviously MVO, you think it's potentially hemorrhage as well. So some of the tissue characterization will better show that, and obviously small pericardial effusion as well.
So these are the long axis cine images.
You kind of see similar things, right? You see the effusion, you see the kind of basal to mid to apical, lateral, both anterolateral, as well as inferolateral wall, which is not moving. You kind of also see the posterior papillary muscle being affected on the 3-chamber there. There's not that much MR though. I would probably just call this trace or physiologic MR.
So these are the LGE images. On top are the cine images, and on the bottom are the LGE.
You kind of start seeing something on the third and the fourth, like the right side slices in that lateral wall, which is affected, but it's not 100% clear. There may be something in the endocardium, but we should look at more LGE images. All right, so here you kind of see this almost near transmural late gadolinium enhancement in the lateral wall. Starts from the subendocardium. I would call this transmural, really. And there is an area in between, which most likely, knowing that this is consistent with an infarct, the LGE pattern is consistent with an infarct pattern, probably is a microvascular obstruction. It could have, hemorrhage in it as well, or it might be microvascular obstruction without hemorrhage. Microvascular obstruction really is when the capillaries in the infarcts are really damaged so that gadolinium cannot go inside it. So you see this kind of area which does not have gadolinium over time. If you repeat it after like 5 minutes, you see lose contrast, but that's what it is. They could be damaged because of distal embolization. They could be damaged because of ischemic reperfusion injury, but it is there and it is a poor prognosis in patients with MI. But you see this kind of large infarct now, which affects kind of inferior and infralateral region with a microvascular, potential microvascular obstruction.
How do you separate just the macrovascular obstruction from thrombus? Because thrombus will look the same.
Yeah, yeah. You use long TI. I don't
think
think.
they did.
Yeah, I don't think we have it in these images. The other thing here is, I mean, because this is an acute setting, it appears that it is within the walls, so it will more likely microvascular obstruction without the long TI images. Okay.
So these are the 2-chamber and 3-chamber LGE images.
You see the same thing, right? You see this large infarct in both the inferior and infralateral mid to apical region with this area, with the area of possible microvascular obstruction within that. It also affects like the base of the papillary muscle here.
We just, Dr. Rakas asked a great question that comes up all the time, differentiating microvascular obstruction from thrombus. You mentioned long TI. Excuse me. You mentioned long TI imaging. Can we just talk about what that is and how that's helpful to differentiate the two entities?
Sure. So, you know, basically when you're doing like mass characterization, you're using different inversion times. So obviously I won't bore everyone with all the physics, but you know, a TI of basically 600 milliseconds or greater is going to very, you know, accurately diagnose thrombus. So if it appears dark on long TI imaging, generally we use 600 milliseconds, that is diagnostic for thrombus. So as part of our mass protocol, we'll do pre-contrast, like, you know, T1, T2 mapping and a long TI. Obviously, this is an acute setting. I don't generally recommend doing a CMR in an ACS patient acutely lab first. But, you know, even if you go to the last shot, especially, it's interesting. If you go to the last slide and you play, you can actually clearly see what Dr. Patel was talking about, where you see this large area of, you know, what looks like MVO on the top, where it's kind of earlier in the course, and then as you're getting later with the late gadolinium enhancement, with more delay, you can see it actually appears slightly smaller. So that's like as with time with damaged microcirculation, you'll see the gadolinium start to slowly diffuse. And that's pretty common. So they typically do the synase. If you're suspecting MVO, which obviously in this case they're just looking to see what the cause is, you might even do like early, late enhancement with a high TI as well, and then do late gadolinium enhancement. And as Dr. Patel mentioned as well, it's the last one, it's the late gadolinium enhancement with diagnosis of MVO that actually is, has strong prognostic indicators and predicts adverse prognosis.
So is another question, just for the audience, you know, it's macrovascular obstruction, myocardium, dead or alive? It's dead or alive, just for the audience. You know,
Well, in this case, it looks very focal. I mean, in this case, I would say that this would be like something, this is transmural infarct that looks dead. I mean, it's microvascular obstruction, it's completely transmural. I agree that this is either a pattern that we would see an embolic phenomenon or spasm most likely. This is not a pattern that you would typically see with such a focal transmural MI with MVO and something like myocarditis. So I think it was very helpful.
I call macrovascular obstruction more than dead.
More than
Yeah, exactly. So and over time, if you wait long enough, the LGE will probably get into that area. And that's why if you wait so long with long TI imaging, that helps differentiate it. Because over time, if you wait long enough after you give the gadolinium contrast, these areas should perfuse eventually, but thrombus will never perfuse, which I think is a really good point. So again, very bad transmural infarct with signs of microvascular obstruction, indicating an acute MI, right? This is an acute process.
So we've also ruled out myocarditis, right? That was like the other big differential that was coming up. So in myocarditis, typically you see like more focal epicardial, subepicardial late gadolinium enhancement, which could be diffuse in severe myocarditis, but more typically it's kind of focal, discrete, might be in like a few areas that are affected. So this LGE pattern is pretty pathognomonic of infarct. So we don't think that this patient has myocarditis, but that's the other kind of thing that the other useful thing that we're getting out of this CMI, that we don't think this is myocarditis anymore. It is an infarct. The question is what is it from, right? It could be multiple things, as Dr. Kukar mentioned. It could be vasospasm, it could be thromboembolic, it could be like plaque rupture or plaque erosion and kind of distal embolization and recanalization, which we can't appreciate on the CAT. Any of those things or SCAD, to differentiate that, you would need OCT. Or IVUS. OCT is better, but we don't have that at this point.
Great. That's a really good point about the myocarditis. Again, anything's possible. You know, could this be a myocarditis? Anything's possible, but it's unlikely given this pattern. I completely agree. You know, focal microvascular obstruction, it can happen with myocarditis, it's just extremely rare, you know. So this looks like a very acute MI process involving probably an epicardial vessel. All right, let's keep moving.
So these are the T1 mated images.
So this is parametric imaging that we do routinely these days, but this is basically tissue characterization, or we're trying to look at T1 and T2 relaxation times of the myocardium to figure out if there's any abnormality in the myocardium that don't detect on other relative images such as LGE and whatnot. So in T1 is basically, just remember what would cause high T1, right? So you see the blood in between, which is red in color. So blood has, anything with water has high T1. So that would raise the T1. The other thing is, of course, you know, fibrosis or infiltration can also raise T1. What would cause low T1? Myocardium has intermediate T1. What would cause low T1? So fat would cause low T1. Iron would cause low T1. So those are the two things that we think about in T1. In terms of interpreting what is a normal and abnormal T1, typically what is recommended is that, so T1 values vary slightly based on the strength of the scanner and the particular sequence that you use. So the best practice is for all the scanners when we start our program, before we start doing this mapping, we kind of scan like 10 volunteers with the sequence we're planning to use and kind of come up with our normal. Right, so our normal is around 1100. So globally, it's a little bit elevated, and regionally, of course, in the area of infarct, because there's LGE, you see more elevation of T1. The other thing that is mentioned here is ECV. So for ECV, you need a pre-contrast T1 image and a post-contrast T1 image and hematocrit. And it's a ratio, which gives you the fraction of extracellular volume. 25 plus or minus 4 is typically normal. So this is kind of borderline, right? Borderline elevated. So those are kind of, so that's what that's the information you get from a T1 map. And then there's T2 map.
So before we go there, Dr. Hadley always likes to mention that parametric mapping is like a virtual biopsy, right? We're really trying to figure out the actual characteristics, the physical characteristics of the myocardium. It really allows us to do that, which is really amazing. So this has become a very clinical process for us. Almost every patient of ours gets parametric imaging now. And it really allows us to look at what the myocardium is really, how the myocardium is behaving. So T1, you know, anything with fluid in it is going to be elevated. Anything with fat is going to be less. Iron is going to be low. So that's always great. You know, if you get like a really low T1, you're like, okay, that's maybe Anderson Fabre's, that could be hemochromatosis from iron deposition. Anything really high, you know, is that something really getting into the myocardium? Is it infiltrative? Is it amyloid? Is it acute MI? Those can give really high T1s. And again, there's diffuse and then there's also focal. So here, because the focal MI causes such a high T1 value, the global T1 is actually elevated in this case as well. All right, T2.
Okay, T2.
So, kind of as we mentioned, so T2 also increased T2 is associated with fluid. So, when you're looking at this, you obviously generally 50 to 55 is considered a normal range. So here you have a value in this area of question of 74 milliseconds, which is high. So significant for kind of focal edema in this area, which, you would classically expect in many kind of cases, like it could also be in myocarditis, but also with perfusion kind of ischemia reperfusion injury with MVO, right? So that's kind of the pathophysiology behind it is, it was ischemic, it reperfused. That, I'm surprised we actually probably just don't image people maybe post-cath. I don't know how often it's happening that we're not picking it up. But that's kind of more dependent on substrate, whether someone is conditioned. Females are obviously more predisposed to develop this, but as the myocardium is exposed back to blood flow, damage, neutrophils, all kinds of things kind of go on downstream that lead to increased edema. And so T2 is a nice way to better quantify that versus us just looking at it.
So as we just summarized, this is just a summary slide talking about everything that we just discussed. So I'll move on. Other labs.
And just one thing,
Sure.
to answer the audience response question that was posed before, if everyone's following along, elevated T1, elevated T2, focal LGE, in this case, again, very indicative of an acute, maybe subacute, but really acute, given the values here of an MI.
I think this case was a little unusual because it was kind of confounding with the inflammatory markers being high and then her kind of presenting with a viral quote unquote illness. So it's very interesting that she winds up kind of coming in with this, what we're suspecting is probably vasospasm versus some kind of embolic phenomenon in that setting. It's like you wonder if it was triggered by it but then everything turned out, I guess on your next slide, bring up the transitioning.
And I mean, to that point, it's kind of hard to differentiate. You would see the same, like elevated T1, elevated T2, and focal LGE even in myocarditis, right? So I think it's just a pattern, and looking at the whole picture together is what kind of helps us give that.
So the viral panel was negative. Lyme serology and anti-nuclear antibody was also negative. EKG prior to discharge has more prominent QAs in 2, 3, and AVF. She was discharged on clopidogrel, aspirin, atorvastatin, and diltiazem. For post-MI pericarditis, she was given colchicine for 3 months.
Maybe just because of the biomarkers, the CRP.
One of the things we didn't see on the MRI was pericardial enhancement.
Exactly. But I think because of the effusion and the biomarkers, they said, okay, we'll give some colchicine.
And the cardiac is probably because of suspected vasospasm.
Yes.
That's correct. Yeah. Because again,
We don't really know.
we don't know, right? It could be. It might very well be spasm. So just in case, low risk, give some diltiazem. That's what their thoughts were.
So it's not in the days before we had fusion of coronary territory, the biomarkers went up a week after the event, but they went up. This is not a surprise. And it doesn't tell you what the underlying is, just it's a myocardial infarction.
Outpatient, there was a repeat TTE done 1.5 months after. EF was 50%. There was inferior akinesis and inferolateral hypokinesis. Repeat cardiac MRI has been ordered and it's pending. A Holter monitor was done and there was a significant PVC burden of 11%. Further management included referral to EP for the high PVC burden, DAPT, beta blockade, and statin. Patient went off calcium channel blockers and also went to cardiac rehab. She also followed with the NYU Women's Cardiology Center, where the angiogram was re-reviewed and no SCAD was detected. Calcium channel blockers were started for possible spasm, and invasive testing was also discussed at that time.
I mean, I think here it's important that, some sort of rhythm monitoring would be advisable, which is what this patient got, given that we not ruled out thromboembolic MI and the reason for thromboembolic MI, so it looks like there's no AFib, that's good. The other thing that is considered, and now that we have it available, is provocative functional testing that Dr. Sweeney does. So not only does it help rule out epicardial vasospasm, it can also help us rule out microvascular spasm, which could be contributing to this. You'll see in reviews that everybody kind of says, oh, microvascular dysfunction may be one of the causes for MINOCA, but the fact is that we don't really have good data about acute MI and microvascular dysfunction. Microvascular dysfunction accounts for a large proportion, maybe like anywhere from 50% to 65%, so 2/3 of patients with stable symptoms, chest pain, shortness of breath, and no obstructive epicardial coronary disease, but we don't really know how it correlates with acute MI or MINOCA. Right, so we don't have good data on that. And the other question that we don't know is whether microvascular dysfunction is the cause of MI, MINOCA, or whether you have microvascular dysfunction as a consequence, particularly focal microvascular dysfunction as a consequence of MI. So for example, if you were to do like a PET of this patient, like 2 months down the line, you are going to see the flows focally down. Like that would qualify as focal CMD, but very likely it is because of the infarct and not the other way around. So that's the other thing. But again, it gets thrown out a lot as, 30 to 40% of the cases of MINOCA are from microvascular dysfunction. We just really don't know for MI. We know for stable symptoms, but not really for MINOCA.
Right, and that was my question for you, was, can microvascular dysfunction cause an MI of this magnitude? Seems unlikely, right?
Yes.
And obviously this person probably has microvascular dysfunction now based on the MI that they had in that territory. But that would, because again, you hear this all the time. And as you're mentioning, microvascular dysfunction and MINOCA, like angina, not obstructive coronary, seems pretty well linked. But an MI of this magnitude seems a little strange.
Exactly. And microvascular dysfunction generally is, you can have focal CMD, but generally is more kind of global in nature, and is less likely to cause an acute event of sorts. But we just don't really know of any good linkage, even though it gets mentioned in every review paper that you're going to read out there.
So let me ask you also, a repeat cardiac MRI was ordered. So what do you think this, so the repeat echo 90 days later, a month and a half later, exactly the same, right? EF of 50, wall motion that was present, still present. Do you expect the MRI to be the same, or what do you expect to see on a repeat MRI 3 months down the line or something like that? A patient like this?
I don't necessarily think that you're going to get a lot more extra value by repeating the cardiac MRI. If you, in a patient with MINOCA, if you had to do an MRI, you should do it early on, preferably within the 1 month of the event versus later on, as studies have shown that you're more likely to pick up acute events, like, if there's myocarditis, something not appear on the 3-month MRI if it's a small event. So if you had to do one, do it early, well, anywhere from like a week to a month after the event, but I don't necessarily know. I mean, it's going to show the same thing. It's going to show that but it's a transmural infarct, so it's going to, maybe the MVO won't be there, but it will still show a transmural infarct in that territory. I don't expect it to change.
Yeah, I think it's probably going to be a transmural MI. Maybe the MVO will improve a bit. That's your hope, is that with time that, there's some lessening of edemas. That's probably what I would expect. And then potentially increased flow in the microvasculature, which would portend better for her. But I'm not surprised if she's having all those PVCs likely coming from that infarct, which is going to be difficult to treat.
Yeah, so she's actually had multiple monitors. Her PVC burden now is over 20%. following with EP. Dr. Rockets?
Did this person had any symptoms in the past, like before this event? She had any chest pains, any symptoms?
No symptoms in the past. This was the first time she presented.
The other interesting thing for this young woman, 55-year-old, right? She had LDL of 188 when she presented with an infarct. So as we know, most of these young women, especially, they don't have risk factors which are diagnosed early. The risk is not managed, and more often than not, they would just present with an acute event. So February is coming up. Please ask your female patients to get their checkups done for risk diagnosis.
We listen to her.
Invasive.
Provocation on this person.
You could, for like if you want to get a definitive diagnosis for vasospasm being the cause of this, if I would probably, if you want to go that route, then probably should get like intracoronary imaging at the same time to kind of definitely get a diagnosis. Was it plaque? What was it? Is structures doing what?
So, and all over the notes from NYU, they want to do that. They want to go in and do like a comprehensive invasive assessment. Obviously, that was not done, which made sense in the acute STEMI, time when this person first had a CAP. But the patient's still thinking it over, per the notes. Patient's not sold on it, which I understand.
You could just treat symptomatically, right? If you think spasm, calcium blocker, beta blocker, she's on both of them, and see if she's improving on that. And if you have, might have a presumptive diagnosis.
So one final question for you guys.
Right, so, we wanted to put this question at the end because we still really don't know what's going on with this patient. We know it's MINOCA. We don't really know what's the cause of the MINOCA. And now that you heard the entire case, you have all the objective data, what do you actually think is going on here? And again, it could be any of the above. But if you would put your kind of, your money down on one process, what would it be? So it looks like a good amount of people are saying vasospasm versus symbolic phenomenon, which is what Dr. Patel and Dr. Cooper were talking about. 20% are saying plaque rupture. 10% say any of the above. Again, certainly possible. Yeah.
So in a study that NYU did, where they did like OCT imaging and CMR in everybody with MINOCA, they found plaque rupture in like 38% of the patients. So it is still accounts for majority of MINOCA, more than vasospasm.
Right, so I just wanted to take some time now to ask the other institutions on the line, if you had any questions for the panel, for the presenter. Now's the time. You can unmute your mics and ask any questions.
Questions from Mount Sinai Morningside?
Yeah, any questions from Mount Sinai Morningside or Mount Sinai West or any of the other institutions? Or just anyone on the line, or anyone here? Any questions for the panel? Yes, Dr. Hadley.
So if embolic phenomenon is still in the differential, what do we think about getting a transesophageal echocardiogram? Do you think that's warranted?
I think it depends on what the CT looked like. Like, was a CT diagnostic for ruling out left atrial appendage thrombus? Also, as Dr. Patel mentioned, that we've ruled out kind of AFib, hopefully a generous Holter in many of them. So I think in that case, we've ruled out embolic phenomena.
Is there a bubble study done? PFO?
Good question.
No,
Probably not.
no bubble.
But I think at some point you have to just think about like what incremental information are you going to get from doing a test, which you don't think, knowing what we know, that we really going to have.
Any other questions from the audience?
The only reason
Yeah.
we're looking is to try and determine future therapy and advice to the patient. This happened again to you, doctors. If you're thinking about beta blocker and calcium blocker, they're sort of antagonistic if you think spasm is the role. Treated like coronary disease. So we really don't know. Embolic phenomena that present only to the myocardium, it happens, doesn't happen terribly often. You know, she would be the first person to present with acute myocardial infarction with an embolization from atrial fibrillation, for example. But we haven't found that yet.
Another thing is, I mean, usually embolic MIs are smaller in size, or at least.
Depends how lucky you are and how quickly recanalization occurs.
The other point I want to make, about Kachubo, say that this repeat Kachubo, like the typical fact, was focal, it still be the Kachubo, but the MRI rules it out, because it shows an infarct, so.
Yeah.
Just to complete the,
Very, very
you
good
have
point.
a focal Kachubo, but the Kachubo, the definition is to recover, so this is dead, so it's not a Kachubo.
Right, and yeah, you don't usually,
Typical form.
you don't really see LG, as you're mentioning, you don't really see LG with Taksubo. You might see some edema or maybe some elevated parametric mapping or imaging. But this is, I think that's a really good point, just to kind of nail that home. All right, any final points from the panel, any final points from the room before we wrap up?
No, I think it was a great discussion.
Thank you so much. Thank you to Dr. Bimmel for an amazing presentation. Thank you to everyone for coming. Until